Thank you all for being here. I want to first of all thank my colleagues, Dr. Reeder, Dr. Campbell, and Representative Cotham for being here as well and joining me on this bill. We also want to thank all the organizations present here today, the North Carolina Medical Society, the North Carolina Healthcare Association, the North Carolina Academy of Family Physicians, National Sclerosis Society, Multiple Sclerosis Society, NC Pediatric Society, NC Psychiatric Society, NC Rare Disease Advisory Council, and Rare Disease Innovations Institute, and Lung Cancer Initiative. I thank everybody for being here today. And I believe that we should all be able to agree that the current prior authorization process is broken here in our state. It is hurting patients, and it's preventing doctors from getting timely care to those that need it. That is why we're here today, and that's why we're starting this legislation. If we're serious about improving health care in North Carolina, it must start with reforming the pre-authorization process. I want to thank everybody again for being here, and I look forward to the conversation we're going to have, and I turn it over to my good friend and bill sponsor, Dr. Grant. Do I say Representative Dr. Grant Campbell, or how many titles do we thought of? For this case, we're going to say Representative Campbell. The floor is yours, sir.
I'm like, you're the rules chair. You can call me whatever you want. So thank you, everyone. My name is Representative Grant Campbell. I'm the representative for Cabarrus and Rowan Counties, District 83. But more importantly, I've been a practicing physician for over 25 years in my community, both at home and abroad, as my time in the Army. The concept of this is very simple. This bill is going to allow physicians to be the ones to make medical decisions for their patients. This is a reflection of we're starting to step between the line of people that are trying to elbow their way in between doctors and their patients every day, and that's a line that gets larger every day. The data that shows the prior authorization issues are 93% of physicians report care delays as a result of prior authorization. 91% of physicians report that prior authorization can lead to negative clinical outcomes. Physicians and staff spend more than 13 hours a week, that's 2 business days, on prior authorizations. These things come with costs, both for the physician office and their staff, and also the insurance industry as well. Those people have to get paid for doing that work, and that is going to be passed along to the consumer, which are the patients that are requiring care. I want to give you kind of a personal example of this to kind of put this in perspective. I've lost count the number of times I've had to deal with prior authorization to get care for my patients, but one in particular comes to mind that I've shared before. Is I had a patient that had a complex ovarian mass that was very suspicious. On imaging, it made the ovary over 10 times the size that it was supposed to be. Our suspicion for malignancy was quite high, and we had her scheduled for surgery. And that scheduled surgery changed 2 times because we went through 2 prior authorizations and then a peer-to-peer review to try to get this approved for this large complex mass in a patient. And when I say peer-to-peer, I put that in parentheses because at that time I'm discussing this case with a psychiatrist that works for the insurance industry that's going to give me approval as to how to take care of this patient. Nothing against psychiatrists. I'm sure if you're a psychiatrist and you had a peer-to-peer review with an OBGYN, you'd be disappointed as well. This ended with me appealing to the Department of Insurance to finally get this taken care of for this patient, and it represented over a 6-week delay in the surgery to find out what was going on with her. I want to put something in perspective too. As a physician, what medication we choose to prescribe, what imaging study we choose to order to evaluate patients, it makes no difference in my reimbursement. I don't get paid any more or any less for the prescription that I choose, the x-ray that I order, the CT or the MRI. We are merely basing that decision on what is best for patients. So I'm going to leave you with this conclusion. We are at a crossroads where we have to make a choice. We have two choices for who decides care for patients. On one side, you have the doctor and the patient who have usually known each other for years. That same doctor has examined them, discussed their options, looked at their testing. And on the other side, you have someone sitting in a cubicle in a corporate office that may be a physician, may not be a physician, may be in your specialty, may not be in your specialty, may be seeing patients anymore, and may not be seeing patients anymore. The parade of people that are trying to interfere with the relationship of the patient and their physician has got to stop, and this is one of the great first steps to do that. So I'm going to pass this along to my friend and colleague, Representative Tricia Cotham, for some other remarks. Thank you.
Thank you, Dr. Campbell, and welcome to all of you who are here today, and thank you for being here for this very important piece of legislation, the Care First Act. I am Representative Tricia Cotham of Mecklenburg County, the Vice Chair of the Health Committee. I stand before you today, obviously as a lawmaker, as a mother, and as a patient to many doctors, some of whom are in this room or outside. I have experienced being denied care, and I want to talk a little bit about some of that. This is a critical issue in our healthcare system today. The relationships between doctors, patients, and insurance companies. When a doctor recommends specific treatment or a procedure, it is based on a thorough assessment of the patient's unique needs, their medical history, and their condition. Doctors have the knowledge and experience to make informed decisions about their patient's care, what's best for them, and often, as Dr. Campbell alluded, when timing is absolutely critical. This bill will require health insurers to consult with the doctor prior to a denial, sets minimum clinical standards, and sets time frames for insurers' care reviews. Of important note, our bill requires timely decisions based on urgency so that patients and doctors are not left wondering for weeks or, heaven forbid, even months if a patient will receive the treatment that she or he desperately needs and what the doctor in that specialty, based on her or his expertise, says is the right care plan. Our doctors must be empowered to educate for their patients. That's why they've gone to medical school. They want to care. They want to take care of our patients. Patients should not have to rely on hope or luck for their quality of life. Let's trust our doctors, the experts. Let's ensure that every patient in North Carolina can have the best and most healthy life for them. The Care First Act prioritizes patient care, restores the physician's authority, and ultimately leads to better health outcomes for everyone. That is what we should all want at the General Assembly. I urge support of both parties and both chambers of the Care First Act. It's an honor to be with you all today. Thank you again. I urge support. I'll now like to turn it over to a gentleman we know and love, Representative and Dr. Reeder, who's the lead sponsor of this bill. Thank you.
Thank you very much, and I want to thank my colleagues who have worked with me on this bill. As you may recall, last session we passed a prior authorization reform bill in the House unanimously, and we didn't get through, so we're back again. Since that time, my patients and the citizens of North Carolina have continued to face obstacles and burdens of prior authorization. What started out many years ago with prior authorization was an idea to think about and deal with complex or expensive care. Unfortunately, this program has evolved and morphed into something that is unrecognizable and really has become indefensible in many ways. Right now, the red tape and delays in care affect simple things like medications, refills even, imaging studies, simple treatments and therapies. It is not just for those complex, expensive things that were envisioned many years ago. My primary goal in filing this legislation is contained really in its title: cut authorization red tape efficiently and facilitate interventions rapidly. Start treatment. The Care First Act. I want to help sure that our patients and their physicians get the indicated care that they need without excessive red tape. In my clinical practice of emergency medicine, you might think that prior authorization doesn't apply to me because most of the things in the emergency department don't require this. But we see this, and my colleagues see this in the emergency department on a regular basis. We had a patient in our emergency department within this last month who had been struggling for weeks to get an outpatient study. Their condition continued to deteriorate. They showed up in my emergency department. We got their MRI. They went for emergency surgery with those risks of emergency surgery. Had this test been done weeks before, it would have been planned. It would not have been happening in the middle of the night. The patient and their family could have prepared for this procedure. It didn't happen. Our patients face the burdens of prior authorization on a regular basis. It's estimated that there are nearly 60 million treatments and procedures in North Carolina annually that require prior authorization. It cost $1.8 billion for this program. You've heard about several of the components in the bill, and you heard from Dr. Campbell about the peer-to-peer responsibilities. And I think Dr. Campbell was correct. We'll need to put air quotes around the peer. I was talking with an orthopedic colleague just last week. He was trying to get a knee replacement for an elderly patient who had been struggling. When he asked for a peer reviewer because it had been denied twice, he was talking to a pediatrician, not a pediatric orthopedic, but a pediatrician who had never done the procedure, never seen the procedure, not even in medical school. That is remarkable and really should not happen. A peer-to-peer should be someone who knows the practice, knows the procedure, knows the conditions for which they're treating. When insurance companies review medical records, they talk to the physician, they make a decision based on the particular medication or test and discuss sometimes with the treating physician. This sounds very much to me like the practice of medicine. Those insurance company physicians required to be licensed in North Carolina in our bill, should be under the direction and control of the medical board in North Carolina. That's one of the provisions of the bill. If you're going to interview, see the medical records, talk to the treating physician, if you do something that is wrong, that causes patient harm, the medical board should have jurisdiction in that. North Carolinians deserve to have their medical care directed by their treating physicians. Insurance companies do have a role to look at expensive or complex medical conditions and have oversight. But their review must be knowledgeable and informed. And so those are some other components in our bill, that it has to be updated regularly and that they have to use the most up-to-date information. Another component of the bill is the transparency that we require in this bill. Insurance companies will have to put on their website the number and listing of procedures, tests, medications that require prior authorization so that everybody can see, so the patients, the physicians know. So when employers are picking an insurance company, they can look to see what's happened. We know in the state health plan, when we switched to a different provider, the report from the state health plan, we went from 2,600 procedures requiring prior authorization to 1,600. So just that change, over 1,000 procedures are now off the list. That's remarkable. I'm happy that the Medical Society and the North Carolina Health Association are here to support this bill today. My time with the Medical Society, I've had a long history with them, and both organizations are dedicated to improving the health care of North Carolinians in the health. And I'm so happy that both the Medical Society and the Healthcare Association are here today. I appreciate their support for this legislation. You know, we've talked a lot about how this affects state lawmakers, how it might help and talk about the insurance companies. But what I thought we could do right now is I want to turn this over to a patient story, because you can hear from me about how this affected us, but I really want to turn this over now to one of our patients to tell the story of her family member. Oh, you're over.
Thank you. My name is Lindsay Franklin. Thank you for having me here today. I'm going to talk a little bit about my son and our experience with prior authorization. I knew little about prior authorizations before our pediatrician sent us to the emergency room with our 9-year-old son Isaac last June. As Isaac's test results rolled in, the number of physicians on his team grew, and we learned that he had an abscess in his stomach causing pain and fevers. In addition to the abscess, Isaac had a section of diseased bowel that was concerning. All signs pointed to Crohn's disease. Though not unheard of, Crohn's disease of this severity in a 9-year-old was not common. Isaac's immune system saw his intestines as the enemy and was working to destroy it. From the ER, Isaac was quickly admitted to the hospital. Meanwhile, the doctors gave us 2 options. One, Isaac could have surgery removing the diseased portion of bowel and placing a temporary ostomy bag, followed by another surgery in 2 to 3 months. The second option would involve draining the abscess and starting him on a biologic medication like Humira. However, due to prior authorizations, we likely did not have time to do the second option. Isaac didn't have time to wait on the medication that his body desperately needed. Isaac had his first of 2 surgeries that summer, just a day and a half after being admitted to the hospital. We remained on the children's floor for a week. Once released, Isaac's surgeon informed us that Isaac had to heal, gain 10 to 15 pounds, and have 1 to 2 doses of the biologic medication before his second surgery. I tell you all of this because this was only the beginning of our prior authorization woes. We were given our options of biologics before we even left the hospital and had decided Isaac would begin Humira as soon as possible. Before we left for the first follow-up visit, Isaac's gastroenterologist and her team were working on what would be the first round of prior authorization for Humira. You see, what I can't stress enough is that time was not on our side. Although the infection and almost 12 inches of diseased intestines were removed, Isaac's immune system was on high alert. It could potentially continue to attack his small intestines and put him at risk of losing more of his bowel. It was almost the middle of July before we received a message that the prior authorization had gone through. A prescription for a Humira starter kit for pediatric use was sent to a specialty pharmacy. And within a week or so, we would learn that the pharmacy no longer carried the pediatric starter kit. Isaac's physician immediately adjusted the prescription to the same dosages that you would find in the starter kit. And since we could not get that starter kit, the gastroenterologist's office had to submit another round of prior authorizations, essentially starting this unnecessary prior authorization process over. Prior authorizations can take weeks. At this point, it was the end of July. Isaac had gained 10 pounds, but the ostomy bag proved challenging. He was allergic to the adhesive, and it didn't adhere very well to an active 9-year-old boy. The surgeon was prepared to do the second surgery in mid-August, but Isaac still needed 1 to 2 doses of Humira before the surgery could be completed. For weeks, I would spend hours and hours on the phone between the insurance company, the pharmacy, and his physician, trying to push the prior authorization through. This is especially difficult when you have 3 small children at home, one of which has specialized medical needs. Isaac would eventually get his first dose of Humira. However, we were told once again we needed yet another round of prior authorization for the second starter dose. Keep in mind, this would all have been included in the starter kit that we had the original prior authorization for. At this point, Isaac's second surgery was scheduled for late August. School would begin in a matter of weeks. He was still struggling with the ostomy bag. We also had no idea if Isaac's immune system was actively attacking his small intestines. Furthermore, Humira is designed to be given every 2 weeks with no exceptions. The starter dose was exceptionally critical to the road in controlling Isaac's Crohn's disease. I began again to call the insurance company, the pharmacy, and Isaac's physician. The doctor's office worked tirelessly on their end, and I was on the phone for hours and hours. The insurance company was aware of Isaac's impending surgery, but the need for repeated prior authorization was placing both the surgery and Isaac's health at risk. Desperate for help, my husband and I reached out to the CMO of our insurance company. Once the CMO was contacted, things did move more quickly. We received Isaac's second dose of Humira just shy of the scheduled surgery date. While I'm so thankful that we were finally able to receive Isaac's medication, I was shocked at the time it took to get my son the medication he needed. His immune system was attacking his intestines. He was also dealing with the psychological and physical challenges of having an ostomy bag. He had a team of physicians fighting for him, and it still took months to get Isaac the medication he needed. Isaac shouldn't have had to wait. A child and their parents should not have to fight that hard in order to get the needed medications and treatments. In the end, Isaac received his medication, had his second surgery, and started school a couple of weeks later than his peers. He's back to playing soccer, being a big brother, and a somewhat normal now 10-year-old kid. However, our fight with prior authorization isn't over. As Isaac gets older, gains weight, or his disease throws his curveballs, his dosage changes. This requires a new round of prior authorizations. I am fighting for prior authorization reform in North Carolina because my son, other 10-year-olds, and other families in North Carolina shouldn't have to. Thank you.
Good afternoon, everyone, and thank you for having me here today. It's just been an honor to listen to everyone and to hear everybody on the same page.
Just a little bit. Just a second here.
Thank you for having me here today. It's actually empowering to listen to everyone and have everybody on the same page. My name is Sumati Iyengar, and I am here today not just in my capacity as a mother of a son with Wiskott-Aldrich syndrome, or was, but also as the co-founder and executive director of the Wiskott-Aldrich Foundation. I represent the families in North Carolina and around the U.S. who are affected by this rare and life-threatening condition. WAS occurs in 4 in 1 million boys and involves two major challenges. The first challenge is they have dangerously low platelets. My son has platelets of 12,000 as opposed to the normal of 150,000 to 400,000, leaving him at risk for life-threatening bleeds. He could never be a normal child. He could not ride a bike. He could not play basketball. The second issue with WAS is that they have a weakened immune system, which makes them susceptible to serious infections. To prevent this, they rely on immunoglobulin therapy, which is essentially a life-saving infusion of antibodies given every 3 to 4 weeks. Along with my son, I also want to talk about Camden, an amazing 20-year-old from Greensboro, North Carolina. I have known Camden since he was 5 years old, just an incredible young man. He's now a sophomore at UNCG, a scholar, and a section band leader who was invited to play in the Rose Parade last year. All Camden wants to do is to lead a normal life and pursue his dreams, but that his reality is far from being true. Despite his condition, Camden has to fight for access to treatment that he needs desperately. Every time there's a change in insurance or a renewal, or he changes the name, the brand name is changed, there's an unnecessary referral for prior authorization. Camden is so immunocompromised that despite all precautions, he has contracted COVID-19 5 times. Because of the consistent delays in his care, Camden ends up in the hospital far more than he should. In fact, it's sad, but he has a room that he prefers, and whenever he comes in, the nurses try to put him in room 928B. So why should a patient like Camden have to go through prior authorization? His condition is documented, his need is documented by doctors, and it has been approved multiple times. It is paramount that prior authorization be reformed in North Carolina so that patients like Camden have a straightforward, easy to understand path where his treatment is approved without obstacles. Unfortunately, Camden is not alone. I hear the same story being repeated time and again. We should be doing better by Camden, by our young men and women, and by our families so that they can live their best lives. The Care First Act will help address these issues by eliminating these unnecessary delays and reducing the burden of care for patients like Camden. Instead of spending hours on the phone with insurance companies, Camden should be at school, studying, pursuing his dreams, and living his life free from constant hospital visits. Thank you for supporting this bill and for making a difference in the lives of the patients and families affected by Wiskott-Aldrich syndrome. Your work will help ensure that kids like Camden can have normal, healthy lives that they deserve. Thank you very much.
So I want to again thank all of the presenters who have been here today, my colleagues in the House to help push this bill forward. As you've heard, this is a big need for the citizens of North Carolina. And we want to advance this legislation to make sure that the citizens and the doctors that take care of them are directing the care and not the insurance companies. We have a number of members of our support team who are here and in the building for other questions. But at this point, we're going to just pause and open it up for questions if there aren't any. Yes, ma'am.
I'm Gracie Tanner, North Carolina Health News. So how does this bill compare to the Senate side? They also filed prior auth reform.
Yep. So I'm really happy that the Senate has acknowledged that there's an issue with prior authorization. If you just go by the weight of the bill, I think there's 6 bills, ours or 6 pages, ours was 16. So there's a lot more in our bill that I think is important for this. In our bill that is not in the Senate, there's requirements for insurance to publicize what requires prior authorization. We have a shorter time frame than what happens in the Senate. In our bill, the peer review the peers that we talked about before have to be licensed in North Carolina is different. In our bill, if the authorization is delayed past the time frames and it is approved. And so there's a number of things that I'm hopeful that the Senate will consider as we debate both bills and move them forward. But I just really am happy and thankful that the Senate acknowledges that this is an issue that we need to deal with.
The other side, of course, the insurance companies say that basically making these changes is going to result in higher healthcare costs for patients. I mean, how do you respond to that?
So that's a great question, and I'm going to shuffle through my notes because I've got...
I'll just acknowledge anytime any legislation is attempted, period, that's always the first response. It's always going to cost more. It's always going to cost more. It's a scare tactic. We believe that we need to put patients first, and this is what this does.
If I can make one comment to that, and look, it's a fair question, but I would put it to you this way, is I don't think there's anybody in the room or anybody in the state that doesn't think that healthcare costs need to come down. But the way to bring down healthcare costs is not to deny healthcare to people that need it. It's kind of like saying, it's really expensive to provide groceries, so we're just going to lock the door and no one can buy food. That's not really the way that we can do this. So, look, we understand the need for it. And the other thing I would say is I would even push back on this not being a cost savings. If I were to tell someone, okay, we have a system that challenges medical decisions, but in the end, both sides have to employ people and pay people to participate in the system. But in the end, almost 95% of the time, the decision doesn't change. I would think both sides would say this is incredibly ineffective. It's not cost efficient. So why don't both sides of this realize the cost and time that's involved and just say, let's save money there and pass that along to the consumers, which are the patients. But fair question.
I think just one other point on that. The CMS looked at this and they passed a rule to change the regulations for prior authorization. It was estimated that it was going to cost savings of $15 billion over the next 10 years. So at least from CMS and regulatory changes from that standpoint, it's actually going to save money.
Grace again. Also another Senate bill is this, that passed the Senate, is the discouraging of health benefit mandates. This would probably fit that criteria of that bill that passed the Senate. Are you worried at all about that? If that became law, then this would require other mandates to be eliminated.
I believe that bill is safely in the Rules Committee at this time.
What he said. I have nothing further to add on that.
If you looked at the process of this, of other states that have done similar prior authorization reforms and how that's played out both in terms of cost of insurance and the patient outcomes?
So we do have some data from other states. There's about, I think, 5, someone's going to correct me, I think there's 20-some states who've already passed prior authorization reform. In Tennessee, they're applied for this. There was no significant impact in the fiscal note from this. Illinois passed it, and there wasn't any significant changes. Wyoming, it increased by $400,000. So we looked at other states, and again, I feel much that although it's a concern about cost and we're worried about the cost of care, I don't think that this is going to add significantly to the cost of care.
Is that it? Thank y'all very much for your time. We appreciate it.
Thank you.